Hey guys, it's Robert Levy, registered massage therapist and instructor of Ligamentous Articular strain technique, and I'm coming to you today. Today is Friday, July the 21st, and just wanted to just doing a quick video because it's been an exciting week. It's been actually really exciting. Not to say that any other week is less exciting than this week, but the week started out with a student of mine from my private group that I teach. Coming in with a distal radial fracture. You probably saw that image on my Facebook page or on my website, but he came in with a distal radial fracture, comminuted fracture that he had acquired from a skateboarding injury. And the nice thing is that he was only casted up to this part of the forearm. So with that cast being only to that point, we have access to this part of the forearm. So the part of the forearm where the proximal radial head attaches onto the humerus and has an influence with the annular ligament and the radial collateral ligament, the supinator, the pronator, long head biceps, common extensor tendons, and we're able to provide treatment to all of those tissues and actually get the radius force coupling mechanism for that radioulnar, radiohumeral joint actually moving quite nicely. There's a lot of stuff that you can do when you've got someone in a cast. And some of that stuff doesn't get taught in a lot of formal education, but from experience and from understanding the anatomy and the physiology and the biomechanics of the tissues, this is what we teach. This is what I teach in my postgrad courses, and especially with the private group that I teach. So it was great to actually have that experience for the private group on Sunday and show all of the members of the private group sort of how to safely, ethically, and effectively treat an acute injury, an acute fracture that improved the quality of life of the patient immediately. So that was pretty cool. The next one that was interesting was another private group student of mine from last year had come in with an acute glenohumeral anterior inferior dislocation, and he had limited range of motion, like almost positive apprehension, positive impingement, supraspinatus. All of that stuff was just really cranky and sensitized. And working with that tissue and again, understanding the physiology, the neuroanatomy, the joint mechanics, the force coupling mechanisms of that specific structure, working with the first rib and the clavicle, and the soft tissue around that area, we were able to get him almost in 100% full active range of motion for all ranges in one treatment. Absolutely amazing, fantastic. It was just, like working with the tissue, taking your time, slowing down, really thinking about the structures and what the neurological tissue is going through, what the joint mechanics are dealing with, what the joint structures are dealing with, and really just taking your time, slowing down, not working really fast, but just working with the body, working with the nervous system, communicating positively with the patient about the gains that you're able to make. It just makes a huge difference in the patient's quality of life and their trust in you as a therapist. So that was really exciting. I love working with, can you tell that I love working with acute injuries? I love working with acute injuries. I got to work with an acute distal fibula fracture earlier this year, and we actually had the competitive female mountain biker back on her bike in about 3 days. So that was totally exciting. The next one that came up this week was a competitive jiu-jitsu patient who 2 years ago was in a competition and had an injury where right at the anterior costochondral joint for the 7 and 8 ribs, they had actually fractured, disarticulated, and no one had ever set them back in place. He had never gone to the emergency room. He just thought that he had a strain or a tear in his intercostals. But he had never had them set, never had them looked at. Just I think he may have gone for an X-ray, but then they didn't really do anything for it. But he said, I've been to see manual therapists, I've been to see massage therapist, physio, I've been to see my physician, And I said, so what did they do? And he's like, well, they worked on my shoulder, my back, and my low back. It's like, well, did anybody ever work at the ribs? He's like, no one ever touched the ribs. And I know that there's lots of you out there that are just salivating right now because you love working with ribs just as much as I do. And this is, again, what I teach in my thorax class, the thorax, abdomen, pelvis class for ligamentous articular strain. For the private group, this is what we teach. We teach how to work with the costovertebral joints, the costochondral joints, the sternocondral joints, and how to look for dysfunctions and issues with the intercostals, and work with respiration and pleural tissue and lung tissue, and how that all connects through to the shoulders and the neck. And he had never had any of that work done before, and it was just an absolutely amazing appointment and experience to go with him, to having restricted breathing and restricted shoulder range of motion, restricted neck range of motion, all because this 7 and 8 costochondral joint in the front had never been worked on before. Now, we're not taking, a dislocated costochondral joint and putting it back in place. We can't do that. But it was movable, and it is movable when he's training and when he's in competition. If he gets hit there or kicked there or punched there, or if he has to use that arm in order to try and pull someone in and use the serratus anterior and intercostals and all those muscles around that area in order to try and win a match, it gets irritated, it gets sensitized. So anything that we can do to desensitize it, strengthen it, and increase that tissue's tolerance for that type of activity that's what our job is to do. The fourth really interesting case was from a long-term patient of mine who'd had a lot of right knee injuries, meniscus, ACL, patellar compression fracture ×2 with reconstruction surgeries that didn't take. It ended up with 6 weeks ago her going in and having a total knee replacement. So she's got a couple of nice crisscross scars right over top of the patella. And the other manual therapists that she's seeing, they're working with getting the range back, and what we need to do is try and get it to like 90, 110, 130 degrees of flexion. But no one's working with the quads. No one's working with articularis genu. No one's working with sartorius, gracilis, semitendinosus, those muscles that really hug around the medial condyle of the femur and attach into the pis-anserine insertion. No one's working with that stuff. And no one's working with any of the scar tissue. Now, I know that from the long-term studies that once the adhesions are set in place, that manual therapy really doesn't have an effect on scar tissue, but we do have the new research from Langevin that shows that within a small period of time, when the adhesions are starting to form, that manual therapy does have the ability to halt or slow the process of those adhesions forming in place. And again, anything that we can do with scars in order to increase the elasticity of the scars and the connections to the subcutaneous tissues all the way down, again, the better of flexibility, movability, strength, decreasing in threat and danger messages from the peripheral nervous system to the central nervous system. I've worked with patients with Harrington rod insertions where they've got a scar that goes from C7 all the way down to L2, and you've really got to sit there and you've got to pick the scar away from where the spinous processes would have been, where the dissolving sutures would have been. So this is what we worked with her knee. And within a short period of time, half an hour, 45 minutes, it goes from having not being able to pick up actually anything from the underlying tissue to being able to pick it up really nice and get a lot of elasticity. And that just makes a world of difference into her quality of life, her being able to function and balance coordination, kinesthetic awareness, moving the knee, strength of the knee. And it's just amazing work to do as manual therapists. The nice thing about this career is that every hour it's something different. It keeps you on your toes. It keeps you thinking a little bit differently. And I've never been one of those therapists that got bored or just wow, it's just a really boring day, nothing new came in, all it was back, neck, and shoulders. I've never had that. I always get these kinds of cases You do get the chronic management patients that you see on a monthly basis, but every once in a while they come in, something new. But this was kind of a fun week, acute radial fracture, acute glenohumeral post-reduction dislocation, chronic costochondral dislocation fracture, and total knee replacement, 6 weeks old. Pretty cool. Pretty fun week actually. So thanks for watching the video. Hope you guys are excited about the career as I am. I'm at 23 years and I'm still this excited when I come into work. This isn't work, this is play. I get to work with my patients and play with my patients and help them improve their quality of life and get back to some semblance of a normal life. If you're seeing this anywhere other than my site, which is lastechnique.ca, then click on over to that site. Hope you guys enjoyed the video, and I would love to hear what type of exciting things you guys are seeing in your practice. So have a great weekend, everybody, and I'll talk to you later. Bye-bye.